Good evening and welcome everyone to the April 10th meeting of the Washington Hospital Board of Directors. It's good to see you all here. Well, I'd like to begin by inviting you all to join me in saying the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Dee, if you would call the roll, please.
Director Nicholson?
Present.
Director Epen? Present. Director Wallace?
Present.
Director Stewart?
Present. Thank you very much. Our next item of business is a very special thing for us here this evening. We as we announced at our last board meeting, Pat Danielson has given us her resignation from the board, and tonight we would like to honor her for what she has done for this board. Pat has served honorably on the board for 18 years and done a tremendous work while she was here, and it's because of health reasons that she can no longer continue. She would love to continue, but we're at a position where she has tendered her resignation, and we need to further in the business this evening. We'll be considering making an appointment to take her place. But it's a wonderful, wonderful service that she has rendered the district. She's been a good friend and a good person to work with. Always willing to do reach out and even do more than she was asked to do. So I'm very, very sad to see her leave. But it's a necessary thing. I'm wondering if any of the other board members have any comments that they'd like to make at this point.
Yes, I'd like to say something.
Sure.
Pat, 18 years ago, or longer than that, probably 19 years ago, when we had the vacancy on the board and we were searching for someone to appoint, just as we are tonight, you were recommended to me by a close mutual friend, and I saw that it was important to find someone with your background in healthcare, and it was a pleasure to get to meet you and a privilege to support you becoming a board member, and you served in that capacity in a very honorable and professional manner over all those years, and elected, and then re-elected again and again. You're just a terrific representative of the hospital, and your energy was astounding. The number of events that you participated is legendary. Not to mention Mrs. Santa Claus and and the golf tournaments where you created quite possibly the most fun game that's out there beyond the game of golf, the whack-a-duck, which I could never master. And as I told you earlier today, it was frustrating for me, but my playing partners gave me all the ducks that they made, and so I have a whole flock of ducks in my office. So it's just been wonderful working with you over these past 18 years and getting to know you, and thank you for all that you've done for the district residents, and we love you, Pat.
Well, Pat, this is Bill. It's been a real pleasure over the last 18 years having you on the board. I concur with what Mike and Bernie has said, and truer words cannot be spoken. It's been a delight to be on the ballot with you many, many times. I know we've run together and always been successful, and that's been a delight to run with you. We'll miss you on the board here. Bernie said we're going to have perhaps someone replace you. I don't think that's true. We will have a new board member, but no one will ever replace you, Pat. You'll be in our memories and our thoughts all of the years. Thank you so much for your service, Pat.
Yeah. Like I mentioned earlier, my association with Pat goes more than 25 years ago when both of us served in the Alameda Public Health Commission. And then since I came on board, you have been absolutely a great friend and a mentor at times. So I won't say that you will be missed, but I think you're already being missed here. Thank you so much for all your services.
Now, Pat, we have a commendation for you. This is a lovely commendation. I think the audience needs to know that Pat in her room has, I'm sorry I haven't counted them, but this will join 10 others, I think. But this one's from the hospital. And I'll come over and show you this.
You need to take the vote on the commendation.
We certainly do. I gave it before we took a vote. I'm sorry. Thank you for the reminder. I apologize. Director Wallace.
Mr. President, I move that the Board of Directors for Washington Township Healthcare District commend Patricia Danielson for 18 years of services as a member of this Board of Directors.
I think this is the happiest second I've done, so I second this motion.
We have a motion and a second. Dee, if you would take the roll.
Director Nicholson?
Aye.
Director Epen?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye. So now it's official, Pat. Now, one more thing. We have a special video presentation. A little bit of a slideshow for you, Pat. This will reveal some of the secrets of Pat Danielson's life, and we'll proceed now with that video. Pat, can you see the screen well here? Good, good.
There's the one of that.
We need you to look very carefully, Pat, at the words on the Newark Clinic. They say the Danielson Clinic, Newark, California.
With the board's permission, we could perhaps take a small break and enjoy the reception for Pat.
Sure. Sure, let's do that. So yes, we'll take just a very short break, give everyone a chance to...
There's a cake in the back we'd like you to take a look at.
Welcome everyone back to our meeting. We've had a lovely reception honoring Pat. It's been nice for all of us to have a chance to greet her and talk to her again and see her. She's a wonderful lady, done some wonderful things for the hospital. I need to make one thing. We're saying bye to Pat. She's moving away. I need to make one thing clear. On our screens, we have the Newark Clinic, and that clinic will now be known as the Danielson Clinic in Newark. If you drive by it tomorrow, that sign won't be there. The sign is an artifact on the picture here. Those things need to be ordered, and takes time, and so I just wanted everyone to be clear of that. Be a wonderful thing to see when it's officially there. So we'll move on now to a consideration of the minutes of March 17th, 11, 13, 18, 25, 26, 27, and 28.
So moved.
We have a motion. We need a second.
Second?
We have a second. Dee, if you would take the roll.
Director Nicholson?
Aye.
Director Epen?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye. Next item is oral communications. These would be any that have signed up to speak to us this evening. Seeing none, we'll move on to written communications, and Dr. Choi.
Good evening. These are the credential action items. The first is the initial 2-year appointments. There's Dr. Wat Lin for medicine, Dr. Joshua Matthews for orthopedics, Thomas Massing, PA, Andrew Maida, internal medicine hospitalist, and Dr. Kuris Simasi Reynolds of orthopedics. Temporary privileges are being requested for Wat Lin and the PA Thomas Massing. For the 2-year reappointments, we have Dr. Abraham Almadi, family medicine, Dr. Shilpa Chetty, OBGYN, Dr. Jacqueline Chu, OBGYN, Dr. James Fields, internal medicine, Cindy Lowe, PA, Dr. Jelriza Mansouri, OBGYN, Dr. Victor Maceda, family medicine, Dr. Nita Patel, OBGYN, Dr. Aruna Reddy, family medicine, Dr. Brian Shea, oncology, Dr. Sharon Singh, neurology. And 1-year reappointments include Dr. Muni Barish, infectious disease, Dr. Reza Malik, neurointerventional radiology, and Dr. Robert Pipkin, cardiothoracic surgery. Under transfer and staff category, we have Dr. Shilpa Chetty, Dr. Jacqueline Chu, and Dr. Matthew Pantel going from provisional active to active, and Dr. Reza Malik going active to courtesy, and Taihang T. Tran, nurse practitioner, going from provisional to allied health provision. Completion of proctoring prior to eligibility for advancement in staff category, we have Christopher Cole, anesthesiology. We have Shil Pachetti, OBGYN, Dr. Jacqueline Chu, OBGYN, and Dr. Matthew Pantel, pediatrics. Extension of proctorship in provisional category, 1 year. We have Dr. Minish Bhamani, Dr. David Carrington, Dr. Cesar Javaharian, ER, Dr. Alex Fox, ER, Dr. Aria Zev Kessler, ER, Dr. Brian Macbeth, also emergency room, Dr. Mark Penner, emergency room, and Dr. Marco Randazzo, also emergency room. Under resignations, we have Dr. Vishal Banthia, Dr. Nisha Gupta, Dr. Shiva Rajael, Dr. Risha Shani, Dr. Sybil Zachariah, and Dr. Joseph Zamudo. That's the end of my report. Thank you.
Thank you very much. A motion on that.
So moved.
Second.
We have a motion and a second. Dee, if you'd call the roll, please.
Director Nicholson?
Aye.
Director Eben?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye. Nancy, we're ready now for our hospital calendar.
We have a service
Oh,
lead
Service league report.
I don't know why
and medical staff.
I skipped 3 people, 2 people. I'm sorry, and I
That's okay.
apologize.
Yes.
Ruth, I owe you particularly an apology. I don't know why my eye just fell right down to the other eye.
Okay.
We'd appreciate your report. Thank you.
Okay, thank you. So on behalf of the Service League this month, we had a big accomplishment. So we'd like to thank the hospital and the board. We implemented what was known as Counterpoint point of service software in our gift shop. So it is now a new, updated, fancy way of collecting money, of tracking our purchases. Debbie Jackson, who was the gift shop manager, spent an enormous amount of time and energy working and getting the staff trained and getting everything organized. So we have really commend her for the effort that she put into getting this system up and going. And the staff here, our information services department, they all worked entirely to help the volunteer services get this new system up and running and going. Some of the benefits that we really are thrilled about is the ability now for employee payroll deductions. We no longer have to manually enter their number. We can use their badge to tap. So that increases accuracy, so we really appreciate that. And also with collecting credit card payments, previously we were only had the ability to accept Visa and MasterCard. Now we are unlimited, so we can do American Express, Diners Card, or any other system. So those are some of the benefits that we are really looking forward to using in the gift shop going forward. So we just can't thank you enough for the in-kind donations and services that you have provided to the gift shop to get that system in and going. On yesterday was the annual Volunteers Luncheon. It was great. It was fantastic, well attended. Food was always good, as it is the Campo de Boche, and we also got to play. So that was also fun as well. So thank you again for the annual day and for the luncheon, which was enjoyed by the Volunteer Services Department. And last but not least for this report is that at the end of the month, we will be having our masquerade sales. And the jewelry sales is always a big item here. It helps with our scholarship fundraising. And for this time, first time, we are anticipating the ability to use Counterpoint remote at that particular off-site location so that will reduce our manual entry for employee deductions later. So we're looking forward to that. So thank you.
Thank you. Do a great job.
Thank you.
All the way around. Our medical staff report now, Dr. Choi.
Well, we are at 599, not quite 600, and our active members are 354 with 104 ambulatory.
Thank you.
We'll get there.
There seems to be a little bump at that.
Yeah, it's like that.
Anyway, thank you. Thank you. Now, Nancy, for
Oh,
the
now it's my turn.
hospital
Well,
calendar.
we'll start with the video. Thank you.
Past health promotions and outreach events. Stroke is the 5th leading cause of death and the leading cause of long-term disability in the United States. Although stroke mortality rates continue to decrease in the district, results of our community health needs assessment show that hospitalization rates from stroke was high for Union City residents. Washington Hospital encourages everyone who is at high risk of stroke to know their risk to help lower chances of having a stroke. The hospital offers free community stroke screenings to help provide better education, awareness, and early stroke diagnosis for our community. On Saturday, March 16th, Washington Hospital hosted the annual Stroke Awareness Day. This free event screened community members for carotid artery blockage, atrial fibrillation, as well as cholesterol, glucose, and blood pressure screenings. Dr. Prabjot Khalsa, neurologist, and Dr. Jack Rose, neurologist and neurointensivist, provided results interpretation. Washington Hospital staff, volunteers from San Jose State School of Nursing, and the Washington Hospital Service League assisted to make this event a success. The event was co-sponsored by Fremont Bank Foundation. There were 81 community members screened. Of those 81, 2 were found to have blockages and 14 others were found to be at high risk for stroke based on other risk factors. For community members interested in participating in the next Stroke Awareness Day, this event will take place again in the spring of 2020. Also on Saturday, March 16th, Washington Sports Medicine sponsored a first aid booth at the 3rd annual Spring Charity Basketball Game at Irvington High School in Fremont. The event benefited the Runnin' For You Foundation, created by NFL athlete and Irvington alumni Robert Turbin. The Runnin' For You Foundation is dedicated to working with charities, corporations, schools, and civic groups to bring public awareness to multiple sclerosis and cerebral palsy in an effort to find a cure for these debilitating diseases. More than 1,000 people attended the event. On Tuesday, March 19th, Father Jeff Finley, Palliative Care Coordinator, presented Advanced Care Planning, 5 Wishes. 26 people attended. On Thursday, March 21st, as part of the Women Empowering Women series, Dr. Victoria Leapart, gynecologist, presented Laugh Without Leaking, Understanding Female Urinary Incontinence. 24 people attended. On Saturday, March 23rd, Washington Hospital staff provided blood pressure screenings along with health and nutrition information at the 5th Annual Community Resource Fair celebration, hosted by Union City Family Center. More than 200 people attended the event and 29 blood pressure screenings were provided. Nationwide, it is estimated that nearly 26 million people have diabetes and 79 million people are pre-diabetic. While diabetes prevalence has remained stable in Fremont and Sunol over the past 5 years, the 2016 Community Health Needs Assessment showed that diabetes hospitalization was high for Newark and Union City residents. Screening for diabetes is important for early diagnosis and proper management of the disease, which is why Washington Hospital offers ongoing diabetes screening, education, and support. On Tuesday, March 26th, Washington Hospital outpatient diabetes staff celebrated Diabetes Alert Day. The event aimed to raise awareness of the seriousness of diabetes, particularly when left undiagnosed or untreated. Diabetes is a major cause of blindness, kidney failure, heart attack, stroke, and lower limb amputation. During Diabetes Alert Day, hospital staff offered a 1-minute Type 2 diabetes risk test along with diabetes prevention education. The event took place at Washington Township Medical Foundation locations, at the Nakamura Clinic and Newark Clinic, and in the lobbies at Washington Hospital and Washington West. 137 people were screened. Community members who are interested in learning more about the hospital's diabetes education program and diabetes support group can call 510-818-6556. The Diabetes Alert Day event will occur again in March of 2020. Also on Tuesday, March 26th, Vida Reed, RN, presented Stop Diabetes Before It Starts. 10 people attended. On Wednesday, April 3rd, Dr. Prasad Kata, endocrinologist, presented Metabolic Disorders. 21 people attended. Upcoming health promotions and community outreach events. On Thursday, April 11th, from 6 to 8 p.m. at the Washington Township Medical Foundation Newark Clinic Conference Room, Dr. Victoria Leapart will present Nutrition Myths. On Wednesday, April 17th from 6 to 8 p.m., Dr. Jenny Tran, Obstetrics and Gynecology, will present Early Detection and Prevention of Female Cancers. At this seminar, learn about the latest screening guidelines along with lifestyle changes you could make to decrease your risk of cancer. On Thursday, April 18th from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart will present Menopause Essentials, What You Need to Know. In celebration of Earth Day, Washington Hospital is hosting Go Green on Saturday, April 20th from 11 a.m. to 3 p.m. Community members are invited to this free, family-friendly event to learn how simple acts can make you and your household more earth-friendly. Residents can drop off unused medications, mercury thermometers, or old eyeglasses. For children, there will be games and activities to learn the impact of small earth-friendly acts. On Thursday, May 2nd from 6 to 8 p.m., Dr. Jelriza Mansouri, Obstetrics and Gynecology, will present Endometriosis, Causes, Symptoms, Diagnosis, and Treatment. On Tuesday, May 7th from 1 to 3 p.m., Dr. Arun Srivatsa, Gastroenterologist, will present Gastrointestinal Disorders. At this seminar, learn prevention and treatment of common gastrointestinal disorders, including constipation, irritable bowel syndrome, and others. On Thursday, May 9th from 7 to 8:30 p.m., Washington Hospital will host Celebration of Life. This event will feature stories of survival and hope for cancer survivors and their families. The event is co-sponsored by Washington Hospital, HERS Breast Cancer Foundation, UCSF Washington Cancer Center, the American Cancer Society, and the Tri-City Voice. Bay Area Healthier Together. Washington Hospital's partnership with ABC7 continues to provide health-related information and education through on-air programming and on BayAreaHealthierTogether.com. The featured topic during the month of March was diabetes, featuring Vida Reed, RN and Diabetes Education Program Coordinator, plus articles on diabetes management and prevention of type 2 diabetes. The Washington Hospital Healthcare Foundation Report. The Foundation will host the 34th Annual Golf Tournament at Castlewood Country Club on Thursday, May 2nd. Held in memory of Fremont businessman Jean Angelo Pisano, the tournament promises a day of great golf and fun surprises. To reserve your foursome or to sponsor the event, please call Washington Hospital Healthcare Foundation at 510-818-7350. The Washington Township Healthcare District Board of Directors Report. Washington Township Healthcare District Board members attended the Indo-American Community Federation's Unity Dinner on March 22nd. The Fremont Chamber of Commerce's State of the City address given by Mayor Lily May on March 22nd, and the Drivers for Survivors annual gala on April 6th. Washington on Wheels WOW Mobile Health Clinic. The Washington on Wheels Mobile Health Clinic, WOW, is a mobile medical unit providing quality health care services primarily to uninsured and underserved district residents. WOW brings Washington Hospital's commitment to patient-first care to clients throughout the district. During the month of March, WOW served community members at the following locations: in Fremont, the Family Resource Center and TCV Food Bank and Thrift Store, and the Irvington Presbyterian Church. In Union City, the Ruggieri Senior Center, Union City Family Center, and Our Lady of the Rosary Church. In Newark, the Viola Blythe Community Services Center and the Salvation Army. These community partners provide social services to families in need and the homeless population. The total number of community members receiving health care from the Washington on Wheels Mobile Health Clinic during the month of March was 78. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The hospital's employment section was March's most viewed webpage with 24,055 views. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a newsfeed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. In Health, Channel 78. During the month of March, Washington Hospital's cable channel 78 In Health captured new programming, including a health and wellness program titled Advanced Care Planning 5 Wishes. In addition, In Health aired the February Citizens Bond Oversight Committee meeting and March's Board of Directors meeting, a Diabetes Matters program called Diabetes and Heart Health, and 2 health and wellness programs titled Aortic Valve Disease Treatment Options, including TAVR, and How to Prevent Financial Elder Abuse and Fraud. Additional events and announcements. On Friday, March 29th, Washington Hospital celebrated National Doctors Day by hosting a luncheon for members of the Washington medical staff. The event was the organization's way to recognize physicians for their service and commitment to the health and well-being of our patients. Awards and recognitions. The Washington Radiation Oncology Center has been awarded a 3-year term of accreditation in radiation oncology as the result of a recent review by the American College of Radiology, ACR. This honor is awarded only to facilities meeting specific practice guidelines and technical standards developed by ACR. The mission of the Washington Radiation Oncology Center is to provide high-quality, cost-effective radiation oncology services to all patients. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070, and please follow us on Facebook, Twitter, Instagram, and YouTube.
And now it's my pleasure to introduce our Employee of the Month, Monette Domingo, RN. She's our nurse navigator at the Radiation Oncology Center, but she has a fascinating history here at Washington, one of which I am very proud. When her coworkers are asked to describe her, they almost uniformly say, very committed. She commits to her work, training, her family, her faith, her patients, and she does it with a full heart. She began her career at Washington Hospital 20 years ago as a clerk in central registration. She soon joined our laboratory as a phlebotomist and then became a senior lab assistant. And she worked in the lab for 11 years, but then decided to go back to school to pursue nursing while working. In 2008, Monette became an LVN, and in 2010, she achieved her credentials as a registered nurse. For the past 8 years, she's worked in the Radiation Oncology Center and is currently our nurse navigator there. At first, her tremendous ability to empathize was a challenge. She says, I pretty much cried when any patient cried, and she admits, but I realized that if I stay strong, it helps them find the strength and the courage that they need. When she first meets with patients, they're scared, nervous, and sometimes angry, and usually very sad. They're overwhelmed by the journey they're about to take, and she joins them on their journey. She offers emotional support and valuable information on how to minimize the impact and stress of their treatment. The education and navigation she covers includes management of treatment side effects, ensuring access to the many resources available to patients. She's a big fan of Drivers for Survivors, which is a local charity, and she works very closely with them on behalf of our patients. Her commitment also extends to her home life. She and her husband, Jeff, have been married for 26 years, and she has raised 2 sons while living in Fremont. As one of 5 children herself, she has a large extended family and loves to cook and plan family parties. When it comes to the patient-first ethic, Monette says without hesitation that the entire radiation oncology team is committed to that principle. We have a close-knit team. We all work together to do what's best for our patients. Very proud proud to have Monette as a Washington Hospital employee. That is a nice journey with Washington.
Yeah, yeah,
Very proud.
good. Our next item on the agenda is our quality report. And Mary Bullrun here to give that? Yes, there she is. Oh, she just came in. Good. And Dr. Martin will join her.
Once a year, we like to give you an opportunity to hear a little bit about our program plan for the year, for in this case, 2019. The program is assessed annually, and we look at various elements that are sort of required by Joint Commission, CMS, the county, and just in general to offer the patients the best quality and prevention they can have for preventing the spread of hospital-associated infections. So Dr. Martin and I this evening will be going a little bit over some of our plans for this year, and some of it which we've already started on. So some background to why the infection prevention program is structured the way it is, and why we look at what we look at, and where we think the risks occur, and the best elements that we can put into place to prevent patients from getting hospital-associated infections are really based on the fact that healthcare-associated infections are a huge issue and concern in the fact that there's 1.7 million healthcare-associated infections just in the United States every year. It is estimated that about 240,000 patients admitted just in California annually develop HAIs, which are hospital-associated infections. This contributes to suffering with illness, increased length of stay, mortality, morbidity, and even a cost of what's approximately about $3.1 billion to the healthcare system. They are also the top 10 leading causes of death in the United States. And a lot of what leads to healthcare-associated infections can be prevented by really having close monitoring, education, and awareness of what risks are happening in your hospital, and applying consistent evidence-based practices to ensure that patients are kept safe. So here at Washington Hospital, we've always had a focus on this program and made sure to keep it up current with evidence-based practice so that we can have an effective plan for preventing the spread of infection in the hospital. One of the ways that this has been done is by implementing the Hospital Infection Prevention Committee. We've had this for a while. We've had it since 2006, and a little bit after that, about 3 years later, we started to actually submit our data before it was required on a federal level to the CDC has a large database. It's called National Healthcare Safety Network. And the sooner you can get your data into them, the sooner you can get it sort of benchmarked and understand where you are compared to other hospitals and their outcomes and what they're doing. They can give us back feedback about, are the hospital-associated infections in your hospital occurring less often than other hospitals compared to your size and type, or more often, and give us some direction with what we can do to prevent them. So been participating in that for quite a while. In addition to that, the program has really been focused on having 24/7 prevention and elimination of infections. And this really includes, having staff available around the clock and making sure that we're doing all these measures consistently with the right people at the right time. That also includes surveillance. We're constantly surveillancing in the hospital. I think you hear I report out quarterly about where we are with our infection prevention. And most of that is based on what we're surveillancing for 24/7 here to make sure that we can have real-time, quick identification of a patient who's at risk for developing an infection or spreading it to another patient or a healthcare worker. So our surveillance is done with all sorts of software, and then that software and that data mining is worked out and submitted to the infection prevention team and then disseminated throughout the hospital with the multiple disciplines that can help us looking at that data. So the people who lead that process is a multidisciplinary effort, and first and foremost, we have a very strong role with Dr. Martin, our physician consultant. She's absolutely the leader and has the vision for where she likes to see the program heading, supports us literally almost every day. We have contact with her and listen to and take direction from her advice as an infectious disease physician to help us guide what we can do to lower our infections. I'm also a part of the team. I have oversight to the infection prevention program, and we have a program manager who is certified in infection control and has many years of experience in working with these types of programs. She requires some support, and we have support in that role by having an infection preventionist. This is a role that has a clinical background. She goes out into the hospital every day. It's very important to have boots on the ground. You need boots on the ground to be in the units, to hear from the nurses and hear from the physicians and hear from everybody about what support they need, what are they seeing going on with the patients, right down to things like, do they have the personal protective equipment, where they need it, when they need it. So it's really important to have that presence in the hospital. You cannot do this job or run this program behind a desk looking at data all day. You need to have presence on the front line. So the other way we accomplish that is we have an infection preventionist who actually works the weekends also, and that helps us get our 24/7 coverage. And we have a rotating call list that we go through so that the night shift and people can have access to the experts that they need to talk to and resources that they need to manage patients and answer any questions for dealing with issues that they may be dealing with at the time. So in addition to that, outside of our program, it's really important that infection prevention works with all the disciplines in the hospital. We have to work closely with environmental services. They are a huge part in how we prevent hospital-associated infections from spreading. We also work closely with the patient safety team, because that's really what this is about. It's about patient safety, and it's about keeping also our employees safe and the physicians and anybody else and visitors everywhere in the hospital. So it really goes across all elements of the hospital. We also work closely with the lab, nutrition services, pharmacy, a big part with antimicrobial stewardship, which you'll be hearing about from Dr. Martin, and all of the different procedure areas. It's also a risk for those patients who come in and have procedures. We need to make sure that we are doing everything we can in those procedure areas to prevent the spread of infection because it's an invasive procedure. And medical imaging, of course. The key program components, as I said, are based really on making sure you have quality and patient safety as your top priority. That always has to be the focus. What are we doing to keep these patients safe, and are we offering it in the best quality that we can with that approach? And that is largely based on antimicrobial stewardship, making sure that patients have the right isolation when they need it. Hand hygiene, of course, is a big focus, which you hear we report on that here quarterly to keep everybody aware of where we are with hand hygiene compliance. We do a risk assessment on various areas. Even when we do a construction project here, we have to go back and look at, what are the risks, even dust mitigation things. How does that affect what can be dug up in soil and everything, and how does that affect patients in the area and the hospital and employees? We do also do a real drill down on, as I said, procedures, but mostly related to what's the outcome with these procedures. Do patients have surgery here later develop a surgical site infection? If they do, we look at that and we do what we call root cause analysis, which is really taking a step-by-step look back to see if you can find any root cause to what led to that patient developing a surgical site infection. It's just one example. We do that with other hospital-associated infections in the hospital too. Staff and patient education is another key component. Is it a component that you have to continue to do all the time? You can never let off from that. This information is changing so quickly. The evidence and how to prevent this is changing quickly. There's staff turnover, there's new people, there's people who need to be, of course, reminded even on an annual basis about what our policies and procedures are. So that continues to be a big focus for us. And as I mentioned, all of our direction is based on sort of current literature, evidence, and practices that come from a variety of groups that we report to. Data reporting is reported in a lot of places on a federal, state, and county level through the hospital. First and foremost, the database I mentioned earlier, NHSN. Of course, we're reporting all of our surveillance to them. The Centers for Medicare and Medicaid Services, otherwise known as CMS, they have access to all the data. If there is a patient here who develops an infection, they know about it. We report it and send it to them. The good thing about participating in that is we can get benchmark data that will help us know where our standing is on that. So I have found that actually to be very helpful in creating any programs that we've, or initiatives that we've made around preventing HAIs. California Department of Public Health, we report to them every surgical procedure, almost every surgical procedure that comes to this hospital is somehow gets back to the state. There's about 33 that we look at in detailed manner to see if, especially if patients develop surgical site infections, central line bloodstream infections, all that data goes to the state. And the state is actually supportive about when they look at the data, they do offer to come in and say, you know, this is what we have found works in other hospitals in California, or what are you doing because you've lowered your rate so much? With C. diff, for example, as you know, we've lowered that quite a bit, and that is something we've been able to share back with our state representative, telling them what we're doing, and they can share that. It's a collaborative effort across the state. And then right here down to Alameda County Public Health Department, we work with them daily. We have an infection preventionist who has a conversation and interacts with these people at the county daily, especially with related to diseases like TB, these sort of things. And they help us, and we work with ID physicians there also who can support us and make sure that we're on the right track with prevention. There are a lot of regulatory oversight to infection prevention programs. This has grown a lot in the last 10 years because of what I mentioned earlier about what a burden and what a difficult problem we have with hospital-associated infections across the nation. So Joint Commission updates it almost every year. They do a little change into how and what we should be looking at. This year, they added on another focus with high-level disinfection, and we won't get into the details of that here, but when you read something like this coming from Joint Commission, you automatically pull together that multi-disc team. Infection Prevention Committee will look at how can we implement this safety mandate coming from Joint Commission, and we try to get that started right away so that we remain current. And also the Centers for Disease Control, CDC, they're very frequently do change, almost annually. They change an approach or a recommendation to how we do things. And this year, they have focused on central line bloodstream infections and made some determination changes in the definition, how we approach those. So we'll be working on that also. I'd like to introduce Dr. Martin now to give you some more insight on sort of how we look at our risk assessment, and that risk assessment determines a great deal of how we'll be spending our time in the program for the rest of 2019.
Okay. So this over here, that's the risk assessment thing. Actually, this is about 3 or 4 pages where we go through almost every detail of our program and try to look at each individual area and then try to risk assessment it or grade it as to what we think is most important or highest area that we need to work on for improvement. So we basically create a risk assessment tool and then basically stratify what we want to address per year based on this. And almost all institutions do that. So it's data that we look at annually. We look at across the board what areas we want to focus on. The ones that we have selected for the 2019 are the hand hygiene and using our what we call personal protective equipment, or PPE, which is gloves, masks, gowns. Obviously, you see diff is top notch on our thing. Last year's numbers looked very good. We've had a little creep up on the numbers recently, but again, we have doing a step back, looking at what we can do to try to improve this. Tuberculosis prevention is always high priority in Alameda County, and especially our area. The Tri-City area that we are in, Newark, Union City, and Fremont, represents approximately 30% of the TB cases in Alameda County. Oakland has 30%, we match them at 30%. So because of our demographics, we see a lot of this, and this is on high alert. There'll be another slide I'll get to in a few minutes that tells you in detail what we do and how we approach this. We're also looking at water device infections, specifically bloodstream related infections. We're looking at water intrusion management. Where do we get leaks? How do we plug it up? How do we keep it safe? And again, antimicrobial stewardship. We decided to look specifically at the CRE, which is carbapenem, which is a particular antibiotic, resistant Enterobacteriaceae. And that's a particular bacteria that's extremely resistant to the most strongest antibiotics that we have available. So it's like water resources in California. Yes, it rained, we have a little more water. Sometimes we get a new antibiotic, we have a little more resources. But there are very few new antibiotics, and the bacteria are getting more and more resistant. They are totally winning this game. Not that we're going to be defeated, we're going to put our very best effort to it. We can match them. So the infection prevention plan is also collaborative between Washington Hospital Risk Assessment, information that comes from Alameda County Public Health, as well as CDC and Medicare and Medicaid services. So the key areas that we want to look at, again, are continuous monitoring of airborne isolation on every unit. So the patients that we are suspecting have airborne infections, especially TB, are put into isolation, and it's monitored. So on the outside of the door, the pressure is monitored so that we can continuously have negative airflow. And if the door's inadvertently left open, there's an alarm, goes to the nurse's station, those things get closed. A lot of times those airflow, especially on 6 West, are way to the end. So that monitoring system is vitally important for us to keep the negative air pressure going. We are working more and more to try to get private rooms, because obviously that's very important. We also reopened the in-house dialysis unit. I think this gives us a lot more control in working with our patients, working with our nephrology consultants, and trying to establish a good quality of care for our patients. So I think this is a huge step in putting back the patient's first ethic to bring the dialysis back in-house again. We're also working on effective data management for the water management. We're updating the competencies on the staff for infection prevention policies. A lot of this is done through the SABA, but there are also other areas where we're working on updating education. I'm a huge believer in education. I think that I'd rather spend time educating somebody than trying to tell them, no, you can't have this, and explain to them why, and get them to be on our side of the team as an advocate rather than an adversary. So our other key strategies are investigating the latest technology for electronic hand washing. Obviously, that's an area we really need to improve on, and it's got to be over and over, and you can't let it slip. Again, the bugs are going to take advantage anytime we slip, so it's very important we keep up on this. So we're looking at this to see if this can help us. The infection control team do daily rounds on isolation patients. One, to explain to them why they're in isolation. I know it's frustrating, it's going to be really boring, and they'd rather be out and roaming, doing other things, going to the gift shop, going to the cafeteria, but we can't allow that. Also educating family, why they need to be wearing masks and gloves when they're visiting somebody. They said, well, they were already at home, I'm already exposed. Yes, but. So we want to make sure that they understand why we're doing this and try to encourage compliance. We do a lot of nursing staff education, especially the charge nurses. I mean, there are team leaders on the floors, and a lot of them have huddles, which are very impressive in communicating information down the ladder so that everybody's on the same page. We've also revised the central line associated bloodstream and catheter associated urinary tract infection bundle. So this is how nurses and physicians approach the patient, make sure that we have all our elements in terms of care covered. We also have updated environmental services with cleaning and sanitation systems. We also revised the Ebola plan. So you're going to say, well, what Ebola? Well, the thing is, it was such a strong program that we had initially, and we'd like to be prepared. And a lot of the elements of that program we can still put into practice on a day-to-day basis. We're also in collaboration with other healthcare facilities. So we have active surveillance of infections, and this is mandated by the Centers for Medicare and Medicaid, CMS, California Public Health Department, and we also on our own do active surveillance of infections. And we list those by risk areas. So influenza, of course, central line associated bloodstream infections, ventilator associated infections. Obviously, most of those are going to be in your ICU and CCU. Central line associated, catheter associated urinary tract infections. We'd like to get that as close to zero as we can. So what the nurses did was institute a bundle where they prospectively look at patients who are on the unit. When could this catheter be out? Is the patient up and moving? Is the patient taking fluids? Is the patient out of pain? So they kind of go back to the physician and say, I really would like for you to look at this. Could you please take this patient off a catheter? And I think sometimes you just get so used to walking in and walking out, you're not really focusing on the whole picture. So the nurses are there in the background, and they've got implementation that they started and pushed forward. Was there physician resistance initially? Yes. Are we on the same team now? Yes. So the nurses really do help come forward and help us identify patients that really can benefit from some changes. Vancomycin-resistant enterococci, MRSA, C. diff we've talked about, and surgical site infections, which Mary brought up, and again, the CRE. I can really go on for on and on and on. I hope you have a long meeting. So the other thing we look at is their ICRA, which is associated with construction. So we do a risk assessment tool, again, to look to see what's the environment that's been affected. Is it a plumbing supply? Is it drywall? Is it something else? There are certain recommendations that's made by the infection prevention team. Our construction team is always very responsive. Robert Alfari will go to bat for us all the time. He is a dynamite guy. Again, the risk classification can be a low risk, like a ceiling tile replacement, all the way up to a high risk where we're totally renovating the pharmacy in terms of their sterile processing. Again, water management is very important. So we look at temperature monitoring, and right now we're doing pathogen testing for Legionella. We probably will expand that more to, say, like Salmonella or other kinds of infections, amoeba, that we could do further down the line. So environmental care is a huge factor in what we do. They're always kind of the behind-the-scenes persons. They're very quiet. They're out there doing their job, but they are a huge part of our organization. And they really go to bat and do the best they can for us. They do in-services. They do huddles. They do one-on-one basis. They actually have hired a new a lead manager who is bilingual and also an educator himself. So he's very adaptable about bringing information to a lot of the environmental services staff. Some of them have a little bit lower education levels, sometimes English not a first language, and so communication is very, very important, and he really facilitates all of those things. And they also do the ATPS testing. This monitors how much debris is left after something is cleaned. So it can't tell you specifically that it's a staph infection or a CRE, but it looks at proteinaceous material. So they're doing that on an ongoing basis, and it has to pass a certain level. If it doesn't, there's an automatic redo of cleaning the environment and retesting. So right now our passing rate is extremely high because all of the workers know that this is critical to our patients' safety, and our patient-first ethic. So antimicrobial stewardship, my forte. So we work in parallel with Centers for Disease Control as well as Centers for Medicare and Medicaid. We're very interdisciplinary. We try to incorporate pharmacy, environmental services, lab, all of those working together, nursing, and try to get specifically reducing our drug utilization. So we look at specific areas where we can make improvement, and this is an ongoing effort. So a lot of times we will step back and look at one particular drug and see where we can make improvements, see where we're utilized, where can we make changes. One, it's a cost savings, but I think, again, it's also saving these very vital tools that we need for antibiotics for when we're really going to need them. So the IDs formed a backup team to be available to physicians 24/7, 365. So if they want one of the drugs that we consider limited to ID approval only, we're available because we want them to use it if they really, really need it. But we also want to provide education to explain to them why something might be a little bit better choice. We are also looking at penicillin cross-sensitivity with cephalosporins. So this has been a very difficult area where people come in saying, oh, I'm allergic to penicillin, but very little information. So was it that I had an anaphylactic reaction, or did I just throw up? So again, we want to educate patients, educate the nurses, so that we can use antibiotics appropriately where they're needed. Because if someone says they're allergic to penicillin and we don't do that other step forward to see what's the reaction, the other thing is to default into one of our higher level antibiotics that might not be the best or appropriate drug for that patient. The other thing we're doing is trying to leverage EPIC. So for someone who's technically challenged, this has been a challenge, but we have an outstanding team behind us that helps. So it's sort of like the guy on the Enterprise goes to the guy and says, make it so. So we go to the EPIC team and say, I want this. And they sort of roll their eyes a little bit. And then they say, okay. And then they help us figure out what we want, how we want it to look, and make it happen. So influenza has been a huge thing. We're hopefully at the end of our season, but there's been a huge impact this year. We had so many people in our ER and so many people that were infected, and just huge numbers. So the CDC estimated we had almost 28 million to 32 million flu cases and 25 to 40,000 deaths, which is a huge impact. So the message here, the bottom line is get that flu shot. So to help prevent the spread of influenza, again, get the vaccine. Is the vaccine 100%? No, but it's better than nothing. So we want to avoid close contact with people who are sick. I mean, if need be, wear masks, wash your hands, cover your mouth if you're coughing or sneezing, avoid touching your eyes or face where you may have the virus, practice good hand hygiene, especially if you're touching surfaces that might be infected. We encourage people to get the flu shot. Even pregnant women, even small children should be getting flu shots. There really should be very little reason why you would not get a flu shot. And again, we want to take home the message that when you have flu, there is an antibiotic for flu, Tamiflu, and also there's a nasal spray, but the regular antibiotics, penicillins, are not appropriate, and they actually won't help you and might actually hurt you. So when you're going to your healthcare provider, whether it's the nurse practitioner or the physician, saying, you know, you really don't, you have the flu, you really don't need an antibiotic, we want people to take that to heart. So measles has been very popular in the press. There have been about 17 cases so far in California. It's highly contagious. Symptoms include fever, a rash that usually starts from the top and goes down, and what we talk about, the 3 C's. So cough, coryza, which is congestion, and conjunctivitis. Risk factors are travel with either outside the country or exposure to people who have been traveling outside the country into the United States. Any areas where there is endemic areas, and also unvaccinated areas. So there are certain constituents that believe that the vaccine is harmful to them and they don't take it, but then they're putting themselves at high risk, and other people who have never been exposed to measles, again, at high risk for getting these infections. The other thing we're working on is C. diff. We changed the name. So it's highly infectious. We definitely want to make sure that in our facility we're maintaining high quality hand hygiene, high quality cleaning, and high quality antibiotic use, because that's the 3 most things that we can do to sort of educate people to use these tools appropriately. We work very closely with the state and as well as Alameda County with respect to C. diff, and they kind of help us partner with learning and approaching patients, and also trying to see what we can do to improve our facility. Environmental services, again, is a huge area. They have done cubicle curtain disposal ones that they basically take down, and that reduces a lot of the fabric that we used to have to put up, down, and cleaning all of those. Again, the pharmacy is looking at drug bug matching, so they're looking at what the infection is, what's your best antibiotic. And then we also did a grand rounds presentation last year. For our C. diff, SIR, standardized infection ratio, we were below the national benchmark for 2018. So We also approach patients and their families, what can they do? So they don't want to feel like, well, I don't know what to do. So again, we want to encourage them when they're going in and out of a room to clean their hands. If they're visiting somebody, they need to use the appropriate PPE. They need the gowns, they need the gloves, and we need the bleach wipes. Our regular wipes are the purple top, and we want to make sure that for C. diff and for the CRE, we're using the bleach wipes. So we encourage patients, if they're going in to see a patient, we have these signs that are quite a bit bigger and that alert them that they need to talk to the nurse who then can educate them. We also have Diana, who's on our infection team, who also does one-on-one education with these families and with the patients so that they understand why they're in isolation, what to expect, what's going to happen. So also at home, if a patient with C. diff is going home, again, Diana educates them so that they know what to expect. Again, hand washing is prime. Cleaning with bleach disinfection is prime. Hot water in terms of washing linens, towels, anything that the person's had in contact with. And then if the patient is given prescription medication, we want to make sure that they take it to completion and that they follow up with their physician or healthcare provider if they have questions or problems, and also to make sure that they are improving. Tuberculosis, as I said, is a huge impact in our area. This again tells you a lot of the things that I mentioned about what we're trying to do to try to reduce this and make it manageable. We notify the county and coordinate with the county on every patient. Most of the times it's a suspect patient, but definitely when the patient is confirmed cases. We again try to keep the patients in the continuous negative pressure isolation to make sure that's ongoing, and annual TB screening is offered to physicians. It's also offered to all of the hospital staff. Again, carbapenem-resistant Enterobacteriaceae, it's again highly resistant to most of our most common antibiotics and some of our really strong antibiotics. What we've done at Washington Hospital again is to use our infection preventionists to educate the patients and the families what's going on, why are they in isolation, what to expect. We have had orientation and education with staff. The infection prevention alert is there in our banner when the patients are admitted either through ER or up to the floor. There's a banner which goes across the top, so the nursing staff is clearly aware that these patients need to be put in isolation. Usually they know ahead of time, but this just reinforces it. Again, we want to use bleach wipes for this as well as the C. diff. So patient education is a huge area that I think we can work on more. We're doing a lot right now. Again, patients who have multi-drug resistant bacteria, patients who have TB, patients who have CRE, patients who have MRSA, patients again who have C. diff. We're trying to reach out with physicians to do one-on-one education, again, like a lot of the nursing homes where a lot of our patients are transferred from here when they have these infections, to make sure that the information goes back and forth so that everybody's understanding what's needed in terms of isolation and how to handle these patients. There's a CRAMES or Elsevier, which is the patient education, which the physicians can access when the patient's being discharged, to include this into their patient discharge information. Again, we also want to focus on staff education, nursing staff, pharmacy staff, micro staff, as well as environmental service staff and our medical staff. So this is a little funny cartoon, but keyboards are highly contagious places, and all of us touch them, and they need to be cleaned regularly, and this is really a challenge. So we're trying to encourage people, wash your hands, clean your surfaces. We did a patient safety blitz, and we also have done the employee health and safety fair. For the future, almost done. Maintain compliance with healthcare associated reporting. We want to do comprehensive multidisciplinary infection prevention rounds. Carmen Akawili in the ICU CCU does that on a very routine basis. We also present information at other formats. So we present to the Clinical Evaluation Committee, Nursing Oversight and Multidisciplinary, Pharmacy, and as well as the medical departments of medicine, family medicine, and surgery. We work with the healthcare associated infections to prevent them in our facilities by isolating patients where possible and limiting transmission. We want to sustain our our improvement. So we basically, once we got going, we want to keep the hand washing high level, high level, high level. We also want to prevent and prepare for any outbreaks, emergencies, and surge protection. Questions?
First of all, thank you. It's always nice to know that we're doing everything we can to prevent infections. It's such a dangerous thing and such a difficult thing to control all the time. It seems like we just beat it away one place and it grabs another. Very, very tenacious foe.
Well, I mean, it's the bacteria are smarter than we think, but I think we're smarter than them.
There we go. We'll maintain that thought.
Thank you.
Any other comments from the board?
I was just, Dr. Martin, lately in the media, there's a lot of talk about the superbug, Candida auris or something like that.
Candida auris.
Yeah. Can you comment on that?
We have not seen that here. We have seen a couple where we thought that might be the case. Initially, that started in a circulation machine that was used for the cardiac bypass surgery. And what happened is most of these are made in Europe, and there was a little flat valve between separating the two inflow-outflow thing, and that flat valve malfunctioned. So they were actually contaminating things, and it's very difficult to isolate this because patients don't always present with symptoms that you would expect. So almost all of them are cardiac bypass patients. And it's very difficult because sometimes Candida doesn't grow very well in a regular media that we use for blood cultures. So if we're highly suspicious of it, we need to do fungal bacterial cultures, fungal bloodstream cultures, because bacteria grows a little bit better at about 37 and the fungus goes a little bit lower at 32. So you actually take the blood cultures and you do them at a different temperature to try to pull it out. So it's been a huge challenge in that we suspect something but can't find it, can't document it. Hopefully the manufacturer went back and did a redo in all of those tanks, pulled out the ones that they thought was causing the problems. So we have fortunately not seen any here.
Okay.
But we're always watching.
Aware.
Well, you know, some are our patients, but some are patients who've had surgery in other facilities.
Yeah.
I mean, we have patients that come from other countries, other part of the U.S., so we need to watch not only for our own bypass patients, but other ones. And sometimes this doesn't show up for almost 2 years. So
Wow.
you have to do a lot of look back and trying to figure out what's going on with it. So it's a huge challenge. Yeah, you're right, huge challenge.
Okay, well, thank you.
Okay.
Thank you again, Dr. Martin. We're now ready for our finance report with Chris Henry.
Okay, thanks, Dr. Stewart. Tonight we will be looking at Washington Hospital's operating and financial results for February. Quick look at operating indicators. Our average daily census for the month was 6 above the budget at 200.8. Our admissions were below budget by 140 at 989, but our patient days were above budget at 167 at 5,621. So that all adds up to a longer average length of stay in the month. Average length of stay was 0.99 above the budget at 5.82. We did have an unusually high number of patients that had stayed more than 20 days discharged in the month. We had some really long lengths of stay discharged in February, so that really drove that number up a bit. Outpatient observation equivalent days for February were 9 above budget at 131. Looking at operating indicators, case mix index for the month, pretty close to budget at 1.486. We had 113 deliveries in February. That's 35 below what we had expected in the budget. Surgical cases were 9 below budget at 361. That included our joint replacement cases that were 12 above budget at 154. Our neurosurgical cases were 6 above budget at 29. Cardiac surgical cases were 5 below budget at 8, and the rest of that variance was rounded out in general surgery. Cath lab procedures for the month were 43 above the budget at 359. In February, we had 7,212 outpatient visits. That's 341 above what we had expected in the budget. And the emergency room saw 4,221 visits. We had expected 4,549. Quick look at the cath lab activity. Peripheral vascular made up the largest piece of the pie at 41%, followed by cardiac procedures and non-vascular interventional radiology. Quick look at productivity. Our productive FTEs for the month were 53.6 below the budget at 1,393.1. We had 171.2 non-productive FTEs, about 13 below budget, giving us total FTEs 66.7 below the budget at 1,564.3. Our full-time equivalents per adjusted occupied bed, which is our indication of how productive we were in the month, came in at 5.56, well below the budget of 6.46 for the month. Moving into the financials, as always, we'll first look at our Governmental Accounting Standards Board presentation, and this is the presentation we use for our audited financials. Total patient revenue came in about 1% below the budget at $182,863,000. Our deductions from revenue for the month came in a little above budget at 79.24%. Take a quick look at how that was composed. Contractual allowances for the month, pretty close to the budget at 76.83%. We'd expected 76.73%. We did have an unfavorable payer mix in the month that drove that number up. But the real story in the write-offs is our provision for bad debt, about 13.6% above the budget at $4.4 million, about $527,000 above the budget. So that rounded out that 79.24% for the month. That left us with net operating revenue about $1.2 million below budget at $38,675,000. Operating expenses for the month came in about $911,000 above budget. And really the biggest driver there is the accounting adjustment we're making in our benefits of about $1.3 million to conform with our actuarial numbers. That drove the largest part of that. Supplies were about $220,000 above the budget. We saw that in prosthesis, in our cardio and neuro supplies. That was offset by purchase services and professional fees that were $48,000 below budget. So we ended February with an operating bottom line from a GASB perspective showing a loss of about $368,000. We had expected a positive income of $1,749,000. Non-operating income for the month came in about $61,000 below the budget, showing a $143,000 loss. That largely driven by our unrealized loss on investments of $141,000. So we ended up the month of February with net income a loss, actually, in a net loss of $511,000. We'd expected about $1.7 million positive bottom line. Quick look at our Financial Accounting Standards Board presentation, and we do a little gymnastics here. This is the way the financial markets might look at us. So we reclassify our interest expense back up into operating income from non-operating income, and we pull out that tax revenue that supports the debt service on our general obligation bonds and that unrealized loss to end up with operating income, actually an operating loss here of about $1.2 million against operating income budgeted at $884,000. Non-operating income, $53,000 above the budget from a FASB perspective at $574,000, and a net loss overall of $631,000 against a budget of $1.4 million. So now we'll jump into our earnings before interest, taxes, depreciation, and amortization presentation. And this gives us an indication of how much cash we actually generated in the month. And even though we showed a negative bottom line in both the GASB and FASB presentation, we did generate cash. So the first thing we do is we look at that operating income line before we recognize depreciation, and we end up with EBITDA of a little over $3.3 million positive. And we also look at our non-operating loss before we consider that interest expense, and that shows a positive almost 1.9 million. So from this perspective, the operation generated about $5.6 million to cover our interest obligations and other obligations of the district. So positive cash flow, it's good. Any questions on February's results?
I think we can move to the operations report.
Okay.
Okay, I'll give you the figures that are preliminary for March. Our gross revenue of $202.6 million for March was above budget by $4.1 million, 2.1% positive variance, and above March of 2018 by $29.6 million. The inpatient gross revenue was below budget by $5 million. The outpatient gross revenue of $57 million was above budget by $9.1 million. The shift from inpatient to outpatient was primarily due to joint replacement. Surgeries being shifted by CMS from inpatient to outpatient setting. Major drivers of our revenue variances were the emergency room revenue, which was down by $3.3 million. That's a 21.2% negative variance. A lot of the emergency room activity is being consumed by the 1152 issue, which we'll get to at the end of this report. So our emergency room visits were below budget in addition to 1152 issues by 126. But that's only a 2.5% negative variance. Cath lab procedures were below budget by 24. And that drove down our revenue by $1.7 million. The room and board revenue was above budget by $1 million. Surgical services cases were above budget by 28 in number, driving surgical services revenue above budget by $4.2 million, for a positive variance of 13.2%. A higher level of inpatient activity drove ancillary services revenue above budget by $3.6 million. The average length of stay of 5.48 was above budget. We had budgeted 4.79, and it was longer than March a year ago. I think we're going to begin to look in a very detailed way at the long length of stay patients and see what some of the common factors are. I would guess, without having done that just yet, that a lot of it has to do with placement issues. Outpatient observation days were 79 above budget at 220 days. Our average daily census of 211.6 was also above the budget. We had budgeted 185.8. That's a 13.9% variance. In terms of admissions, we were 79 below budget at 1,123. The major drivers of the admission variance included inpatient cath lab admissions, and those were below budget by 1. Inpatient surgeries below budget by 28, and that again is the joints moving from the inpatient to the outpatient arena. Our deliveries were below budget by 13. Our medical admissions were below budget by 37. In terms of patient days, we had 6,560, and those were above budget by 799. Surgical trends. The total surgical cases for March were 405 and above budget by 28. The inpatient surgeries were 28 below budget. The outpatient surgeries were 56 above budget. The increase in outpatient surgeries is again joint replacement. Neurosurgical procedures were below budget by 5. Joint replacement surgeries were above budget by 1. Cardiac surgical procedures were above budget by 3. General surgical procedures were above budget by 29. The cath lab procedures for March of 354 were 24 cases below our budget. Yet they were 6 above a year ago at this time. Inpatient cath lab procedures were below budget by 1. Outpatient cath lab procedures were below budget by 23. Our cath lab activity in cardiac procedures were below budget by 27. Peripheral vascular procedures were below budget by 1. Neurointerventional radiology procedures were on budget at 6. And non-vascular interventional radiology procedures were above budget by 4. Deliveries for March were below budget by 13. They came in at 139. Non-emergency outpatient visits of 8,114 were above budget by 350 visits. Cardiac rehab visits were above budget by 213. Infusion visits were above budget by 49. Rehab visits were above budget by 43. X-ray visits were above budget by 29. And prenatal diagnostic center visits were above budget by 29. Emergency room visits of 4,840, surprisingly enough, came in below budget by 126 visits. Productive FTEs were above budget by 50.5, or 3.6%. Non-productive FTEs were below budget by 14.6. Our total FTEs of 1,594.5 were above budget by 35.9. Total productive FTEs per adjusted occupied bed of 4.98 were below the budget of 5.78. Total FTEs per adjusted occupied bed of 505.41 were below the budget of 6.36. Our other operational statistics include the Washington Outpatient Surgery Center volume. They had 501 cases in March. This was just 2 cases below the budget. The clinic visits of 3,803 were below budget by 273 visits for the month of March, but were above the volume March a year ago. Washington Urgent Care was 47 less, Nakamura 47 less, Newark Clinic 139 less, Warm Springs 11 visits less, and the Ohlone Clinic 29 less. The preliminary payer mix information for the month of March was not favorable. Government-sponsored patient revenue made up 73.9% of total gross revenue. We had budgeted 72.1%. And given the fact that the federal government has never paid the cost of care and that it has been cost shifted to commercial insurance, this is not a good number for us. HMO revenue was 2.4% of gross revenue, and that was below the budget of 2.9%. PPO revenue was 21.2% of gross revenue, which is below the budget of 22.7%. And that's probably the most significant negative variance. Private pay revenue was 2.5% of gross revenue, which is above the budget of 2.3% and above last year. And that is, again, the trend of people being uninsured and coming to the emergency room without any financial sponsorship whatsoever. Days cash on hand for March ended at 148 days, up 3 days from the prior month. The days of gross revenue and accounts receivable were 54, and that remains a very strong figure. And the business office employees are to be commended for that kind of a performance. There were $558,723 in charity care applications pending or approved in March, which reflects the trend that I just commented on. The next slide relates to where we are with the homeless patient activity. And this is the, I've now come to call the 1152 report. It refers to the Senate bill designation. In March, we had 222 homeless patient encounters. Patients that had more than one encounter numbered 39. The impact of having them here in terms of incremental cost was $95,554.77. The estimated unreimbursed cost of the homeless care was $397,238. And the year-to-date estimate for the cost of homeless care is now at $1,692,640. And you can take a look at where the patients touched the system, 88% of them in the emergency room, and 11% went on to become inpatients, observation patients, 1%. So you can see how it goes.
Okay. Thank you, Nancy. At this point, we're going to move to our action items. We've already handled item A in the commendation for Pat. Item B is a consideration of applicants for the appointment to fill the vacancy on the board of directors. So tonight, the board will consider filling that position. At the March 13th board meeting, the board established a process and a schedule for filling the vacancy by appointment. By the deadline of submitting applications, which was March 27th, the district clerk received 5 applications. The board members, 4 of us here, have all had an opportunity to review those applications. As a reminder, the board asked that the applications include a letter of interest, a resume, a conflict of interest disclosure form, and the information absent any personal information was uploaded to the district website last Friday along with the agenda. Now I want to thank all the people that applied. There were some very, very impressive achievements and resumes in those applications. Really good people that have done a lot of good things. And sometimes it's very difficult to sort through those and figure out the best approach to take. Tonight, I want to proceed as follows. I will ask the board if they have any preliminary comments, after which I'll open it to a public hearing. If anyone wants to speak, including any of the applicants, they may do so at that time. I will ask anyone who wishes to speak to limit their comments to 3 minutes. Dee will be on the clock on that, and we'll follow her direction. After the public comment, after everyone's had a chance to speak on that would like to, I will close the public hearing and bring it back to the board for discussion and possible decision. After the board members make any comments, I will entertain a motion to nominate one of the applicants. If there's a second to the motion, we will have further discussion regarding that applicant and then take a vote. If a majority of the board votes for that applicant will be appointed. If, however, there is not a majority, then we would consider another applicant, another motion. If there are no further motions for nominations and no one has been renominated by a majority of the board, we will then switch our discussion to considering the next steps, which would include further discussion at a future board meeting. So that's our plan. With all of that in mind, I just ask the board if they have any preliminary comments before I open it to a public hearing.
Well, I would just like to thank all of the applicants as you have, and it's a rewarding but daunting responsibility, and I just want to thank you for your interest, and whatever occurs, I encourage your continued participation in the healthcare of our district. So thank you again.
Any other comments?
I would just agree with Mr. Wallace that this is a very important decision that this board will make, and I feel that the district is very blessed to have had 5 fine applicants show their interest to serve, because there's a lot of service involved in this service on the board. The challenges ahead are quite daunting, as we saw in the financials today, and so I do want to thank all 5 applicants who applied. We appreciate their interest.
I think
That's pretty much echoing the same thing. I mean, I just want to thank all the applicants who have taken time to volunteer to do this. Again, thanks.
I'm going to open it now to a public hearing and invite the public to address the board. And if any of the applicants are here and want to address the board, now's the time. As a reminder, we'll keep that to 3 minutes. I must announce also that one of the applicants, Steve Chan, has notified me that he had a conflict tonight that was set up long before this meeting, and he felt morally obligated to be at the other event. That's one reason he's not here tonight. But I thought that was important for everyone to know. So we're now opening that to public comment. Any public comment or any one of the applicants that would like to speak, I'd invite you to come up now and speak. Yes, there's a familiar face. Would you introduce yourself?
I'd be happy to. My name is Jack Rogers. Long-time resident of your district. In fact, in 1958, I think, was the first paper boy for this hospital. I'm here at the request of Steve Chan. He asked me to come and say a couple words for him. I've known Steve, and I was surprised when I first started to put this together, for a little over 30 years. We first met because our children are about the same age, and they played soccer together, and so we found ourselves touring the state with a competitive soccer team, his son and a couple of my kids on the team. My next interaction with him happened in the 1990s, when some of you will remember the city of Fremont, or this area, experienced some pretty dramatic storms, and it led to a slippage up on Mission Peak. A very large landslide, in fact, and Steve and Sue became active in our community. I was working for the city taking care of a lot of public work stuff in those days. So we had a lot of interaction. They represented a community group that wanted to make recommendations to the city on policy and how we might work together to solve some of those problems. That led to another interaction as I got ready to, right after I retired, about 2005. Steve and Sue approached me and asked me whether I'd work with them to help with Celebrate Fremont, or our year-long celebration of 50 years of the city of Fremont. And so we worked together quite a bit over about 2 years, trying to raise some money and put on a year-long celebration that I think turned out to be pretty successful. That led to Sue and Steve committing to, actually Sue committing to run for council, and Steve and Sue approaching me and asking me whether I'd help as their campaign chair on that event. And so you can see that we've had lots and lots of interaction. In addition to that, I and my wife have been very active in supporting our community hospital. And I can't tell you the number of times we've run into Sue and Steve doing the same type of work, supporting this community hospital. My point is, and the reason I share this with you, is that I've witnessed Steve's interactions with his family, his interactions with his profession, his interactions with his professional organizations, his interactions with the city and other governmental agencies, and his support and commitment to this hospital, our community hospital. If past behavior is the best indicator of future behavior, the board of directors will find a willing and talented supporter in Steve Chan. He'll be a colleague, I'm just about done, who should you select him, you'll find to be a great asset for our community and for this hospital. So, thank you so much.
Thank you, Jack. Appreciate you coming and doing that. Do we have anyone else that would like to speak? Yes.
Thanks for giving me this opportunity. In fact, I have some write-up. That was about 5 minutes, so I don't know where to cut it. It's going to be about 3 minutes, but I'll try to do it. The point I want to make, all of my education has been in the medical school. And
you should introduce yourself.
Oh, okay. This is Rakesh Sharma, and I've applied for one of these board opening and asking you to consider my application. So I was born in India, and in 1977 left for Japan on a scholarship and worked at Research Institute of Nuclear Medicine, which was next to the Hiroshima Hospital where my wife did some fellowship. And in 1980, I came to Stanford Medical School Department of Radiology, and I worked about 18 years at the Stanford, and finally went to Caribbean at Seba Medical School to teach there, and I was like associate professor and chair of clinical biochemistry, teaching medical student, and that was my last job in academia. Our older daughter, Natasha, was born at Washington Hospital, so that's how long we've been associated with the hospital. She's doing surgical residency at San Joaquin, our older daughter, who is also a medical doctor. And as you all know, my wife is a family physician in the town. I have been all-time community person. I've been in Fremont for now over 32 years. I've been planning commissioner for the city of Fremont, and all of you know what one has to go through at that time being a planning commissioner. In fact, Pacific Commons was built when I was planning commissioner for the city of Fremont. I've been president of the Niles Rotary, the greatest Rotary club on the planet, and being its president in 2010 and 11. And let me tell you the truth, this was the most rewarding experience of my life while doing our community service. And we meet right in this room. I can really list you a lot of other things that I do. I love Fremont. I'm going to die in Fremont. I'm going to serve. What happened tonight is not an issue for me. You're going to make the right decision. You have to. I'm a founding president of a nonprofit, Fremont-based nonprofit called Indo-Americans for a Better Community. I've been board member to Life Elder Care. I was involved writing their new bylaws. I've been with Chamber of Commerce. I have sit on the board of American Association of Physicians of Indian Origin, organized a lot of health fair, and I thank Washington Hospital to really support and help on all the health fair that we did. That was all passed. Even currently, I'm involved with quite a few things. I'm still the current president for Indo-ABC, a great organization that has kind of done charity ball for the last 16 years, and I have been involved with it. And they have donated over $800,000 to Tri-City area. So I'm very committed to work and as a volunteer. So I deliver Meals on Wheels for 10 years, and work for Adopt a Street program, whatnot. The point I'm trying to make that this is my community. I love it. I have time. I have passion. I have been in medical environment. I've worked in hospital and medical school situation. I have not been a practicing physician, to be clear very, very, very nicely. But the only thing I want to say, if appointed, I will work with all of you guys to help hospital provide best health care to its local community. Furthermore, if appointed, I promise to run for Washington Township Healthcare District Board in 2020. And I've gone through this election, and I know how much effort and what it takes to run for election. And at the end, I tell you, I love this hospital. We have chair, top hat, and past. The hospital operates on patient-first ethics, and that is really the bottom line. And the second bottom line is that whatever gain and the profit that this hospital makes, goes back into it. That helps serving the community need for all the medical purposes. So just if you look at those two things that this hospital is known for, you really can't beat it. And anybody who's going to be the part of it should be very proud of it and should do all it can to achieve that goal. Thank you.
Thank you, Rakesh. Thank you very much. Are there any others that wish to address the board here this evening? Then our public input, public hearing are now closed, and that brings it back to the board for discussion and possible motion. I'd just like to, again, thank the applicants. You know, this gets to be a very difficult thing. As you've all heard here tonight, the two that have spoken, these are very, very talented, very, very qualified individuals. Each of the board members have had their resumes. We've read those over, we've studied them. This is the first time we've come together to talk about what we've learned. And in the overall scheme of things, we're going to have one person that's excited, four that are disappointed. And, you know, I like to have everyone happy, but that's an impossibility here. We've got to stand and carefully exercise our discretion and carefully make a decision that is best for the district. And so I'd open it now to a discussion from the board, whichever.
Mr. President, as you know, this is a very important decision for the board. I have read the applications and I've considered the public comments. From my view, one applicant stands out from the rest, and that is Jeannie Yee. I'm prepared to make a motion, but also I am willing to listen to anything that my fellow board members have to say. And let me just say that my reasoning is as follows. Jeannie has been an operating room nurse. She has a background in healthcare in a very intense situation. She has served on the Hospital Service League Volunteers since 2003, 2 terms as president, 2 terms as a secretary, and 3 terms in the tough job as parliamentarian. And it's good to know we have a parliamentarian expert around here. Some of you guys could use some correction every now and then. She presently serves on the DevCo board and serves in that capacity as a Treasury Secretary. So she has a long standing involvement with the hospital. Not to say that a couple of the other applicants have also had a very, very good relationship with the hospital over many years, and I appreciate those applicants very much and encourage continued participation. But as I said, I'm prepared to make that motion, Mr. President.
Are there any other comments that we could have on that while we're discussing that particular candidate before we call ask Mr. Wallace to make a motion?
I would concur with Mr. Wallace in everything that he said. I've been very impressed with Jeannie Yee in what I've had the opportunity to observe over the many years that she's been a part of this institution. Many of my patients are volunteers in the Service League, and I think all of them respect her leadership, her intelligence, her thoughtfulness, her caring, and her ability to innovate and seek responses to the challenges that have faced that particular organization. So I see an individual who has the skill set and the background, having been a nurse and maintaining an active license as a nurse, as an incredible asset on this board. As I said earlier, the challenge before this board is daunting in the current economic and healthcare environment that we face. And we need somebody on this board who can assume that role running from the start. And so as such, I too, along with Mr. Wallace, would support the appointment of Jeannie Yee.
I've known Jeannie probably since being on the board for 16 years, and I have found her to be a very, very dedicated person, someone who's somehow keeps the interests of the hospital first. And in that regard, I see some very positive things about her possible service on the board. Are there any other comments from the board that we need to take into consideration at all here? Then, Mr. Wallace, perhaps if you'd make a motion, we'll...
Mr. President, I move to have Jeannie Yee fill the vacancy created as a result of the resignation of Patricia Danielson, and to fill the remainder of the term until December 2020.
Mr. President, I second that motion.
So we have a motion and a second. So we're at a point D where we would need to call the vote.
Director Nicholson.
Aye.
Director Eapen.
Aye.
Director Wallace.
Aye.
Director Stewart.
Aye. So that motion passes. So I would congratulate Jeannie on her appointment, and I really feel again to say that the other applicants were extremely well qualified. These are very, very good people that have offered to come forth from the community and offer their services. As all of you remember, earlier in our meeting tonight, we approved the minutes of 8 board meetings in March. I can give you some help on that. That's a record. At least in my tenure, we've never done.
That's a record in my 29 years.
So,
record in my 35 years here.
all right. So I don't want to discourage anybody with that. But anyway, good. Well,
I'm glad you brought that up after Jeannie got.
Good. Well, anyway, congratulations to you, Jeannie. We'll be anxious to work with you. We'll make arrangements for a proper swearing in, and that will come, and we'll get that arranged and get that announced. That's the end of our agenda here this evening. We have need for a closed session meeting, so we'll adjourn this meeting to a closed session. Good evening. We announce that we're reconvening to an open session and announce that no reportable action was taken during the closed session this evening. Good night, everybody.